Well, Steve, first of all, I just want to thank you for your service to our country. You played an incredible role in a very challenging time, and so thank you.
Well, thank you. I appreciate it. Thank you.
The talk was incredibly interesting. I had seen it before, but with your experience, your career, you have perspectives from so many different angles on the topic that you talked about. And I'd like to continue the dialogue here a little bit. So lots of learnings during COVID, and as you mentioned, we were trying to do our part in infectious disease. But what would you say, what were the new lessons that we learned from COVID, from developing tests and new tests? And what have we learned that we can apply for new cancer tests?
So you mean specifically around diagnostics?
Yes.
Yeah, I think we learned that it's not going to be perfect to begin with. That's one. It's going to take multiple iterations to get to the ideal product.
Right.
And we need the regulatory flexibility to allow us to have that give and take. One thing that worked really well during the pandemic was, okay, you don't have to wait to complete your study before you submit the information to the FDA. We'll give you feedback, and then you'll go back and do some more studies and come back. And let's give you the time to actually do that. I think the other thing is we definitely need a different and enhanced and better regulatory framework around diagnostics.
Yeah.
It's muddled. The pathway is not completely clear. It's very expensive. And the rules of the road aren't completely clear.
Yeah.
And I think we've seen some recent issuance of potential rulemaking by the agency. I'm not sure it's quite where we need to be, but that needs to change. I think also, can we use novel approaches for clinical evidence development? Do we always have to go back and do the same old, not same old, but the same studies over and over again that are very costly, that involve hundreds of thousands of participants in studies? Are there different ways that we can do this in silico, et cetera? Are those going to be acceptable to the regulators? Are those going to be acceptable to providers? So that we don't need to have that long period of time for development process. So just a couple of things that I think would be potentially movable for all of us.
Yeah, and you're kind of talking about collaborating across organizational boundaries there, right? So what do you think? What can we do as an industry? We have different stakeholders in the room here to help facilitate and enable what you're talking about.
Yeah, I think that was one of the major lessons from COVID, right, was that people collaborating around a single problem could really do some great work.
Yeah.
And there isn't any reason we can't do it with cancer. Now, we have competitors, right? We all do. But in our approaches, in the platforms we use, in the thinking about this, so there's a role for academia, great basic science. There's a role for engaging the payers early around this, right? I mean, I totally believe, having spent time at MD Anderson, that the payer actually is pretty aligned with the patient and the healthcare, well, maybe not completely with the healthcare system, but bring them into the fold about, okay, what evidence do they need to help them make decisions around reimbursement?
Yeah.
And engaging patients and consumers early. Yeah. This whole issue around, how do you build trust? And again, it's somewhat branding, but I think that's really important. And then finally, not to be forgotten, the provider. Because it doesn't matter if you have a great test and great science, if they're not going to use it because it's too hard.
Yeah.
And I know that sounds horrible, but we always need to understand how can we make it easy for the provider to do the right thing.
Yeah.
That's an important part of this. And thinking about that early, and then what information you're going to provide and how they deploy that information to take care of their patients is critical.
Yeah. I think we were chatting about it the other day, but some newer diagnostics takes up to 15 years to ramp to reasonable usage in the clinic. And if you think about it, the career of a clinician, that might be half of someone's career, right? So the whole topic of how you deploy and help facilitate deployment.
And using technologies that they didn't even learn about in medical school.
Right, right.
And what we've heard in the MCED landscape interviewing providers is the number one concern they have is fear.
Yeah.
What am I going to do with the test?
Right.
If it's negative, and my patient, Mrs. Jones, comes back with a metastatic breast cancer a year later, like, what am I going to tell that patient about a negative test? So not to to underestimate the need for negative predictive value. I mean, you got to be pretty darn sure when you tell someone, no, I don't think you have cancer. It's not like your cholesterol is normal now and in a year it's going to be high. That's a totally different equation. This is a high-risk situation.
Yeah.
So fear of that. What if I do have a cancer and I don't find it? You haven't told me where to look.
Yeah.
And am I going to get sued? What's the family going to say to me? There's the fear things that we've heard. And then finally, a really significant and vexing problem in cancer screening is overdiagnosis.
Yeah.
We are seeing studies now, we've seen them for years in prostate cancer, who needs to be treated versus who can you watch and wait. We're now seeing that in breast cancer across the globe. Who doesn't need to have the full treatment associated with her breast cancer? So these are issues that come forward. And when you think about a 50 or 20 panel MCED, that's even more, right? I mean, all those cancers, understanding which are indolent and aggressive, there's biology behind it that we can exploit, but it is a problem that we have to solve.
Yeah.
So all of those things will go into this issue of adoption.
Yeah.
Because the doctor's not going to order it if they don't know what to do with the information.
Yeah. So lots of challenges or opportunities.
Opportunities, you bet.
But many different ones. But what would you consider to be the biggest challenge within cancer diagnostics today?
To me, the biggest challenge is access. It's not the science.
Mm-hmm.
I think the science is there and will continue to be there, but it's the access.
Yeah.
And as I mentioned, the access issue is multimodal, right? It's can the grandma from East Texas actually get the cancer screening? That's one. Then if they're diagnosed with a cancer, can they find a hospital to go to where they're going to treat? I mean, not everyone's going to drive to MD Anderson to get treatment, right? In fact, 85% of people don't. So do they have access for that?
Right.
So there's that part of it. But then there's the affordability component.
Right.
So the grandma in East Texas needs to be able to have access from an affordability as much as the person in the coast who's going to a concierge doctor and paying out of pocket for it.
Yeah.
We can't have that discrepancy. So that's a big component of it. We can't solve all those issues, but we can help people solve those issues.
Yeah.
And then there's the side we just talked about on the adoption side. Because again, patient's not going to probably order this test, at least not in the next 5 to 10 years.
Yeah.
So again, making sure that you've talked to the stakeholders about what they need to make the clinical decisions is key. And by the way, the FDA's approach to this, I believe, will be very similar to what we're hearing from doctors, patients, et cetera. And that is, when they look at the efficacy side is pretty straightforward. What's the MPV? What's the PPV?
Right.
But the safety side of this, how many people are you diagnosing, or not diagnosing, but identifying as having a positive test who you're sending for a workup who don't have a cancer? And if that's a large number, first of all, payers understandably will hate that. But think of the tests that you're subjecting people, but also the stress for patients and their families. So all of these stakeholders need to be considered, and all the information that develop. Now, we can do it, I believe, and we've got to have solutions for them.
Yeah. Steve, it's always so great to talk to you and hear your different perspectives. I'd like to open up to the audience to see if we have any questions.
Thank you, Steve. Wonderful presentation. I'm curious, what are your thoughts about, when we think about prevention, how do we make the actual patient population, or not the patient population, but the whole population, to really go into preventative healthcare? We know that it's been super challenging to even drive education about lifestyle, about diet, about exercise, to have preventative lifestyle. So how do we think on changing that behavior so that we can really go into preventative and early detection of cancer?
Yeah, it's actually a huge issue. One of the biggest issues, Vanessa, is alignment of incentives. At least in the United States, it's probably not true in single-payer healthcare systems. The alignment of incentives around preventative health, outcomes, cost, et cetera, aren't necessarily there. What do we incent in the U.S. healthcare system? What does Medicare, for example, pay for versus what they don't pay for? So can we align the incentives so that all the stakeholders are thinking the same way? Because as you point out, it's better for patients to actually do those things early to prevent or to stave off disease than once you define that. We refer to that at Flagship Pioneering as a sick care system. That's what we have, as opposed to a well care system. So that's the first, is how do we align the incentives? Then there's the whole issue around changing behavior. And I think, again, and maybe I have too optimistic of a view, because it's really hard to change human behavior once certain behavioral patterns are established, but it can be done. I'm thinking about, again, cardiovascular disease. So if you think about the identification of all those risk factors, people didn't pay attention to their hemoglobin A1C in 1964. I mean, it wasn't even probably widely available. No one got their cholesterol checked. Mm-hmm. And yet now we have a time where everyone kind of knows about it. People talk about it at cocktail parties, and now we have Ozempic and Mounjaro and all of other drugs that potentially help with some of these problems. And I think we can get the same place with cancer and other diseases. It is, however, about identification of the risks and having that conversation that, yes, you can do something relatively straightforward to modify those risks, and then the outcome coming. Again, can't take 50 years to get to that, but I do think that there's a paradigm that we've used with cardiovascular disease that could work for other diseases, including cancer.
Wonderful. Steve, I love your whole, what if attitude and approach. And we're so excited about your venture that you're in right now, and we think you're going to do great things there with your team. We look forward to following that. Thank you so much for your time today.
Thank you. Thank you.
Thank you.